This lecture will focus on pediatric patients with some special needs. The special needs term, unique needs term is just big, wide umbrella. Anything from learning disabilities into physical and cognitive disabilities, impairments, chronic illnesses, any behavioral issues. So when we talk about special needs and unique needs with children, just know that that covers a wide spectrum. And in large part, these children do thrive in their home. There is improved survivability from a lot of these conditions, and healthcare technology has come a long way. So quality of life has improved quite a bit, and length of life has improved quite a bit. Just as a quick statistic, across the country, 20%, 1 in 5 of children under 18 have some sort of special healthcare need. So we're talking about millions and millions of children. So not one-offs, you will be encountering these unique needs children. Our general approach to our special needs population, it's going to be the same as any other child. We're making sure the airway is clear and patent, looking at oxygenation status, making sure that cardiac status is adequate, and then we're going to understand the needs of the child. If there's any specialty equipment, we're going to have to understand that equipment, and then basing all of our assessments on the child's baseline, physical needs, mental abilities, and coordinating with their caregivers, parents, guardians, and the like. Here are some basic questions to kind of add into the mix when you've got a special needs child as a patient. Asking about norms, asking about that baseline, asking about communication with the child, how they communicate, if they can communicate, are there any sensory issues you need to know about, cognitive levels, and how can you tell any changes with the patient. So the question, how do we know if the patient is scared? How do we know if he is in pain? So let the people around the patient, their caregivers, let you know, how does the patient respond to different things? What do these behaviors mean? And then collecting all these special needs information and adding that to your pertinent medical histories. The parents and the caregivers of these patients are by and far the best resource for helping you treat and communicate with this child. They know that equipment inside and out. They've got specialized training, and they may have replacement equipment. There are things you can take with you, or equipment that they can monitor and handle during the transport and during the treatment of this patient. They may also have extra information, extra documentation on hand, old charts, records, and things like that. As for specialty equipment, some common ones that you will run into, looking at shunts for CSF and intracranial pressure, tracheostomies, vascular access devices, and gastric feeding tubes are common, and then vagal nerve stimulators have become more and more common. So getting into these specialty pieces of equipment, special situations, one is hydrocephaly, in which there's excessive cerebrospinal fluid, especially within the ventricles of the brain, and just causing signs and symptoms of hydrocephalus. The patient may have a shunt placed to drain that CSF. So if that shunt becomes blocked in any way or malfunctions in any way, we'll start to see neuro effects. So it's good to know if they have that shunt in place. Are there any? Is there anything we can do to evaluate that shunt, troubleshoot that shunt, and getting as much information on this patient as possible, especially their baseline as neurosymptoms set in. So we want to catch these neurosymptoms as early as possible, so they might have a little difference in level of consciousness, maybe complaining of headache, have some nausea, vomiting, changes in speech or behavior. These early signs of shunt malfunction and increasing intracranial pressure, or later signs, especially with Cushing's reflex, seeing that high blood pressure, low heart rate, and those irregular respirations leading into unresponsiveness and abnormal posturing. Now, what should we do as paramedics when we come up with, or we come into a shunt that is malfunctioning? We're going to keep the head raised, try to keep it raised, and supporting our ABCs, right? Supporting our airway, providing oxygenation if needed, assisting ventilation. Can't do anything about the shunt itself, but if anticonvulsant medications are needed, we can administer those, and then any other management of increased ICP that we can provide on our way to the hospital. Children with tracheostomies may have this trach for a number of reasons, and these trachs can be switched out or changed every day. Some can stay in a little bit longer. They come in cuffed and uncuffed varieties, but it's just this airway in the child's neck, and we often get called out for tracheostomy issues when they get maybe clogged. We need to go in, we need to suction and help change it out. And then home ventilators. Definitely talk to your caregiver about this ventilator. They're going to know everything about that ventilator and that model. You might not be trained on that model or the patient's setting, so the caregiver is going to know everything about that vent. Please talk to them, please coordinate with the caregivers, and knowing that children can be very sensitive to ventilator changes. So even just tiny changes in those vent settings, or even just a different model ventilator, the child might not respond well to. Children on home ventilators using a BVM, usually not well tolerated, so we'd like to keep them on their own ventilator as long as possible, even during transport, if we can transport that vent with us. Alright, next, let's talk about vascular access devices. And these are these catheters, these central catheters that are in place long term, kind of like a portacath or a PICC line, peripherally inserted central catheter, instead of that child being cannulated and having an IV over and over and over again. One of these will be placed surgically and can last for months at a time. So the patient might have some sort of central venous catheter feeding straight into the superior vena cava here. Usually has 2 or 3 ports there on the end of it. Most EMS protocols call for us trying to get an IV line established before we access any of these indwelling catheters. We don't want to damage these indwelling catheters. So if we can get an IV line, we'll get that first. If not, last resort, we can use these as access sites. Same thing goes for portacaths. This is access site usually in the upper chest, just underneath the skin, and then with a catheter going into the subclavian vein. Again, protocols call for us trying to get some sort of peripheral access before we access these. We do need special equipment to access a portacath so we don't damage the portacath itself. But you'll see this again in patients with long-term treatments for things like cancer, let's say, and instead of IV access over and over again, they'll have this portacath implanted, so when they go for treatment, they can access that portacath there in their upper chest. You might encounter children with feeding tubes. They're surgically placed to feed a child or remove air fluids from the stomach. So common names for these tubes, there are PEG tubes or G tubes or J tubes, but you'll run into these feeding tubes in children. We are typically called out when there's an issue with that feeding tube, that PEG tube, that G tube. Sometimes there's an occlusion, and we can go out. We can aspirate a little bit, try to clear that occlusion. Do some air aspiration, maybe remove some air from the stomach, and decrease maybe respiratory distress. And so if we need to bag a patient as well with a G-tube, we can remove air from the stomach and aspirate air. If the tube has become dislodged, treatment is fairly simple and straightforward. Just cover the site, and we'll take them for further treatment, further assessment, and a physician can either replace the tube or come up with other options. And finally, vagal nerve stimulators are becoming more and more common. There'll be a device implanted in the upper chest, and then electrodes running up to the vagus nerve. It is activated by a special magnet on the outside of the neck. So placed against the neck, it activates this device. So if the child feels a seizure coming on, or maybe they have a caregiver who sees the beginnings of a seizure, or they have a service animal who initiates this, they can activate this device and try to interrupt the signals in the brain and stop that seizure. As always, if you have any questions, please let us know.